Hello, everybody. Welcome to Hit 200. Today is February 18th, 2021. So, we're going to obviously go over the quote of the day, make sure we have our minds right, make sure we are in great spirits. I said spirits. Um, we're going to take a quick look at what's due this week. I know Will Smith gave you guys a little bit, but I wanted to break it down a little bit further than what he did. And then the real chapters are chapters 14 and 15, like he had mentioned in the agenda. And then we're going to wrap everything up. All right. Quote of the day. Today is another chance to get better. Often we look at things and we may have those down days, those days where we feel that nothing we're doing is going our way. The kids are crying, you forgot to get gas to put in your car and you got to drive all the way across town and you're just feeling like you're just having an off day. But just know that when you wake up the next day, it's another chance to get better, to feel better, to leave all those worries behind and look towards a better future. I truly believe that positive thoughts help with negative outcomes. I'm that person that's like, oh man, today sucked, but tomorrow I have a chance to do better. So that's just a little something to take you from this Thursday to next Thursday. All right. So this week, which is week 7, we have what, 4 weeks left? 8, 9, 10, 11. This has been going so crazy fast. In your apply and reflect, you have 9 short answers based on a scenario. So today we're going to do kind of like the scenario that you will see and determine how to come up with different information based on the scenario that you have. So it's just one scenario and 9 questions that you have to answer based on that one scenario. Okay. And like I said, it's a statistic scenario. So we're going to kind of break it down so that when you go to do that apply and reflect, you'll have a better idea of what they're looking for. When you talk about your discussion forum, you're looking for articles related to reimbursement in healthcare, revenue, or Medicare billing and fraud. You don't have to find an article that has all 3 in it, but you're just looking for an article. It can be a YouTube, it can be a TED Talk. Get creative, okay? So you don't necessarily have to, do the typical, write this discussion board out. Be creative. So if you see a YouTube video that talks about it, add it in. If you see a TED Talk, let us see so that we can discuss what we read or what we see. And if you have an article, you can add the link to the article and just kind of let us know what that article is about to kind of open up the discussion so it's not just a response. We're going to take it to the next level for these next 4 weeks. You'll notice that when I respond, I try to respond with different articles and videos. So to kind of show you, hey, this is another way that you can do it to help add supplemental information to the conversation. Then you have your week 7 quiz. It is 20 questions, multiple choice, and you will have 30 minutes to complete it. Okay. So plan, reflect, scenario, 9 questions to answer based on that scenario information. Discussion forum, you don't necessarily have to just type in a response. You can reply with a YouTube, you can reply with an article, a TED Talk, anything that you feel is interesting. And you have your quiz for week 7, which is 20 questions, multiple choice, and you have 30 minutes to complete it. So we're getting into the money. All right. Talking about everything that has to do with statistics, why we have it, the role of reimbursements, the insurance companies, and much, much more. When we talk about health statistics, what do you guys think we're talking about? Like, what is health statistics in the first place? What are some of the factors that we're really looking at? And can you see these little pictures? Probably not. Think about some of the things that you have seen even in the news when we talk about statistics. One of the biggest ones, COVID-19. There's a huge statistic on that. What were we looking at, or what are we still looking at, as the numbers are starting to slowly decline on a, I want to say, daily basis?
Well, the number of cases and and also the
Yes,
number of deaths
yes,
and the hospital
yes,
beds and everything.
yes. That is basically what we're going to be talking about today. I brought up COVID because that is our most recent thing that we can all relate to, because we're living through hopefully a downslope of a pandemic. When you talk about health statistics, it includes both empirical data, estimates related to health, mortality, morbidity, so death, risk factors, what patients are more prone to get more serious symptoms. And I'm going to relate it to COVID because that's what we are all hearing day in and day out. What health services are covered? You know, are people able to get the vaccine without having to pay for anything? What systems are even providing that information or that service? Is it just the hospitals? Are they having mobile places open up? Petco here in California. Some areas have Rite Aid and Walgreens and CVS. So the different systems as well. How is the information getting disseminated? How are we finding out about these statistics? Um, the World Health Organization, of course, is going to mandate different members, states in its constitution. However, how are we getting that information? So I'm going to throw another question at you. Why is this so important? Why is health statistics important in the first place? Like, why do we need to know?
Is so we could see trends like right now with the pandemic, for example, like you said, or new viruses or that kind of stuff.
Definitely. And with that, good job, Miss Rika. And the mutation, you've heard of the COVID-19 mutation that's going around now. Like this thing is getting smarter, right? We, just like she said, we're identifying trends. Healthcare providers, they can monitor local conditions in their area and compare them state to state. Which states are having more prevalence of that mutation as opposed to those that are still having the same old strand, that now we have a virus vaccine or a vaccine to kind of help prevent people from getting deathly ill from the virus. It helps to give allocations to the public or the private to determine what areas need more help as opposed to others that may need less coverage. When we look at different sources of health statistics, it includes national surveys that they can put out, health faculty assessments, and then routine informational systems where we have so many amount of vaccines going to this particular state. How many of those vaccines are actually first doses as opposed to how many of those are second doses? How are the facilities able to keep track of patients, and which vaccine are they getting? Are they getting the Moderna versus the Pfizer? On top of that, how are you keeping record when somebody comes back for their second dose to know that they originally got the Moderna and now um, they need to make sure they have that second dose of Moderna as opposed to giving them the Pfizer? When we look at the number of sources that exist, that can be potentially used to generate these statistics, they include, like I mentioned, the surveys, the health facilities, assessments, the same information where we're actually trying to gather. They're the same ones that can provide the information out. So, I mentioned in your activity that you guys have a statistics question. It is a information on a patient, and I didn't want to go word for word from that one, so I changed it a little bit, but to kind of break it down for you. So in front of you, you see that there's a trauma one hospital and it needs to audit because there's patients that are getting a lot of wrong site surgeries. They go in for a left cataract, they come out with surgery on the right eye that didn't have a cataract, and so on and so on. So I went extreme to kind of break it home. There were 7 cases in which patients had to remain in the hospital. We're going to look at the information from below to determine the average length of stay in the facility. So you have your cases 1 through 7. And when you go to the exercise, it sends you to another site. So you'll copy and paste that information into your search, and the information will pop up. I wanted to make sure that it did. So I did this before I even created the scenario, just to make sure that you guys would have that information. Now, there are some parts here that I didn't add because I wanted to bring it on a smaller level. And granted, we only have really 45 to 60 minutes. So I really want to make sure we can break this down so you guys can really get it. So this is going to be just your CPT code, right? Not really stressed about that. I made them up. You have your length of stay. LOS is going to be your actual length of stay. You have your charges, and then your payer, Medicare, Medicaid, managed care, etc. When we're trying to find out the length of stay for statistical purposes, and we're just doing the average, right? Because you're going to have outliers, meaning, of course, 3 and 12 are going to be your outliers because they're going to be very small and very large. So you want to know, what is that average? So before I give the answer, what do you guys think the average stay is for this particular Trauma One hospital for these patients that have had wrong site surgeries?
I don't have a calculator right now, but I'd say take all the lengths of stays and divide by 7.
Yes. So when you guys do your statistics, okay, there is a length of stay one there. All right. So that's why I think it's maybe the second or third one. Granted, it's not the same information, but you would take the length of stay for all 7 cases. You would add these all up and divide by 7. So the average stay is 7.43 days in this hospital due to wrong site surgery mistakes. So I'll repeat that because you do have 9 answers kind of like that. Okay, so you're taking the length of stay, you're adding each one up, dividing it by the 7 because there's 7 cases and you want to know the average for all 7 cases. So you divide it by 7, and then it just happens that this one is a 7.43 days in the hospital. Why do you think that's important to this particular trauma facility? It's the fact that they keep operating on the wrong side of people. What do you think they're trying to do? I guess I should say.
Allocate for space for the
Okay.
patients.
Yes, that could be one. Definitely good answer. Anything else? Think about how expensive healthcare is. With all of these wrong site surgeries, think about how much they're actually paying out, right? Or charging. They're charging the payer. Let's say that a patient is scheduled for a left breast biopsy. So their payer, Medicaid, Medicare, managed care, etc., is only going to pay for the diagnosis from the CPT code of a left breast biopsy. However, during the procedure, something else happened where instead of a left breast biopsy, the patient had a right foot amputation. And I'm going extreme, okay, right? Because that's way too different, but let's go with me. So now they had already been, insurance had already approved, had already, gotten all the paperwork in place for that left breast biopsy. However, when billing sent the new CPT code to the payer, it now had, instead of the breast biopsy, a elective foot surgery on top of the foot surgery, it was actually an amputation. That's a problem, right? Because then I would not want to go to this particular hospital, because not only are you doing wrong site, you're all in the wrong body part. Like you're going from general to ortho. Okay. That's an issue. So then you're looking at the billing department. You're looking at the operating room department. You're looking at the PACU, the recovery. You're looking at every single department to try to find out statistically what is going on. Okay. You could also take the information and compare it to other things. So like I said, when you actually do your exercise, they'll have more identifiers, more information added, male, female, charges, the actual cases, and you can get statistics for each and every single of those things based on what we're looking for. But I really wanted to kind of go over an actual scenario, because your activity is all scenario based, and it's like not hard math. It's just kind of like, all right, so we're going to break this particular down. They're looking for, in our example, length of stay for all the patients, so that we have to go ahead and make sure we add them all, divide them, multiply, whatever we need to do to get that percentage or number that they're looking for. Okay. And if you have any questions, just email me and I can kind of like break it down for you a little more if you need more. But this is the basis of the scenario. It's only one scenario, and it breaks down to 9 different questions they're looking at the same data. So it's the same data, but they're just looking at different things. They may be looking at the pairs, how many pairs of this particular thing had a diagnosis code of 599. The charges, how many of these charges have been more than 10,000, et cetera, et cetera. Now, don't quote me on word for word, but just trying to give you an idea of what you're going to be expected to kind of look at. All right. So grab a calculator if you're not good at math, just to have it with you to get the percentages and the numbers that you'll need for that particular scenario. And just keep in mind that these scenarios are really important, because that's how we were able to determine what ethnicities were being hit harder with the COVID-19 as opposed to others, when it came to demographics, when it came to socioeconomic status, and different things. So statistics are being used as we speak, even today. Okay. How is the information used? This is also a good question. We use information daily, weekly, monthly, and sometimes in a specific time frame. Statistics is given healthcare able to make different decisions with that information. We can plan facilities and services to monitor inpatient and outpatient revenue streams. So we take that information and we adjust our plan of actions based on what level hierarchy we are in the healthcare setting. All right. So I did this so that you can kind of see, picture somebody just sitting in a room looking at different statistics, and they're able to create graphs and forms. We looked at data and graphs last week, so we're bringing it in today. And that information that we are getting from these statistics, we're placing on graphs to be able to present it to the individuals that need it to be able to make the decisions on the next steps. Okay. Census data. The chapter talks a lot about census data. We're looking at the population, characteristics, the age, the sex of individuals. Are they married? Are they single? Are they in a domestic partnership? Do they have some type of household composition? Like, what is the family made up of? What are the family characteristics? What's the household size? Are you looking at a husband and wife with no kids, as opposed to Aquamom and yeah, Aquamom? That's all I can think of right now, because she has a lot of children. Yes. So this, I'm the same way. I had to take statistics, but this is a different type of statistics on a not so high level, I think I want to say. Think of more of as a census data. Okay. So we're looking at a census data / instead of statistics. Census data is used and mandated by Article 1 and Section 2 of the Constitution that takes place every 10 years. When what we do with that information by the census is determine the number of seats each place has. So when we're looking at census data for healthcare, we're looking at slightly different things, but we're also wanting to make sure that we are providing the right amount of health care for individuals. Another thing we look at, if you look on the bottom, we look at our payers, how people are getting or taking care of their healthcare bills, how they're being billed, who's paying for it. You have employer sponsored insurance, where of course you're at your employer, they help pay for your insurance to help subsidize. Medicare, Medicaid, other private coverage, of course your military, and then there's still a portion of the population that is uninsured. That's important because especially with the coronavirus, when people were getting sick, this was really used to determine how many of those individuals that are actually really sick going in and getting the care that they need. A lot of individuals were not going in because they didn't feel they could because they were uninsured. So you take the statistics and kind of use it to figure out what you can do for the population. What items are reported on daily? Looking at the picture above, what would you say are some of the things that we look at on a daily basis when it comes to daily sensing of healthcare information? Just throwing it out there with the patient, with what you see right now on this slide. Infants, beds, death, definitely. We do death rates. We do net death rates, unfortunately. And I wanted to really separate newborns and adults and children because they are reported separately. Just so you know, newborn births are reported differently than adults and children. When we talk about the daily census, we can look at weeks, we can look at months, it can be divided over a period of time. We can look at the number of days in a specific time period based on a specific ICU versus PACU versus recovery, okay? We look at inpatient beds. We look at the percentage of occupancy. How full is this hospital? This helps to determine how we keep hospitals open, believe it or not. If you have a 150 bed ICU suite and on a daily basis, they only have 3 or 4 patients, somebody's going to come and look at that unfortunate facility to determine, do we really need y'all here? And sometimes it's just like that. You look at, you have 150 total bed, that's looking at the occupancy. We're looking at the bed count. I mentioned 150. On top of that, with that ICU, how many days were there 4 or 5 patients actually in the ICU? So not only are we looking at 150 bed ICU with only 5 patients, we're looking at how long those patients were actually occupying those beds. It can be greater than 100%. With the death rate, it can be correlated to autopsies. We can look at autopsy rate, fetal loss, newborn autopsy rates. It can all be related. I wanted to put this up here because it will show you how to come up with the gross death rate as opposed to the net death rate. When you're looking at the opposed or the gross death rate, let's say, like it says on the thing, you have 22 patients. You are going to multiply that by 100% to give you a 2.5 or 2.6%. Okay. As opposed to the net death rate. I'm getting tongue tied. And on the scenario, make sure you have this up if you need to go and have it side by side because the formulas are here. So you have a 50 inpatient deaths, right? 15 inpatients within less than 48 hours. So we're talking about how many patients were not able to be successful in life within less than 48 hours. You can do 24 hours, you can do 48, 96, 72. You just want to know how many patients died within that less than that amount of time. So instead of just multiplying by 100, you are looking at less than 48, 15 did within that time period times 100 to give you the discharge, including deaths. So when we're talking about discharging patients, unfortunately, those numbers do get thrown in. So if you have 100 patients that were discharged with an additional 5 that passed during that same period of time, instead of saying 100 discharges, you actually have 105. Make sense? A little bit? Make sense? Okay. And like I said, you'll have the actual PowerPoint with the archive, so you can come back to this particular section if you get caught up on those scenarios. Now let's talk about the revenue reimbursement. We're talking about the revenue cycle management, how it works. This is the process of a patient financial and health information moving into, through, and out of the healthcare facility. We're looking at how facilities receive payment. So it goes hand in hand, right? But we're looking at how they're actually getting their money. What things have to be in place for people to get their compensation of revenue. Management of the revenue cycle is a process of supervision with claims. You always hear about claims. Got to put in your claim for this. You got to put in your claim for that. Why is it important to us? Well, you have your experts in coding, making sure that those codes that I mentioned in the beginning are correct. So a patient that went in for a breast biopsy and actually had the breast biopsy doesn't have to go back because the claim was for a right foot amputation and vice versa. So having your coding correctly for the right procedure is important. Documentation management. You go in and you are the one verifying the document, making sure that John Doe, who did have the amputation, is actually having the correct claim for that amputation. You have the accounts receivable that will, after the CPT code is in place and the person has gone over it to make sure the document was managed correctly, then they're going to give it to receivable so they can go ahead and do their part. Basically, claims, they're filed so people can get money, the facilities can get paid. The extent to which effective management of the processes is how everything is handled. If there is a good process in place, usually patients can go through the system flawlessly. But if just one thing is not put in place correctly, it can cause a catastrophic domino effect where you're now going back to claims and the patient's having to go back and make sure that the surgeons, they have their surgeon notes, right? Then they're comparing that to the actual CPT code. And now the CPT coder has to go and make sure that, and it becomes a whole domino effect. So what is revenue management to you after what I've explained? What would you identify as a revenue management? How would you describe it? And you can use the chart up here to kind of come up with different ideas. Move my little cursor.
When you say revenue management, is it for the facility?
It can be facility, it can be for the individual. When you're looking at the chart and what I just explained, how can you understand what revenue management is?
I mean, I guess for the facility, how much money they're receiving for claims, and basically how much money like out of pocket that the patient would have to pay. And then
Yes.
for the patient, I would think that it would be them staying on top of their claims and knowing, exactly what they're paying, so they're not being overpaid or double paying.
Yes, that's good. That's good. Anybody else have anything?
Yes, I want to piggyback off of, what is your name again, sir?
Shut up.
Brian.
Brian, I'm just gonna piggyback off. I think, I would probably start at the AR management, because it's like,
Okay.
with patients, collecting, I guess, the information, making sure everything is on point. And then from there, I probably would go into the analysis, like, the payment, and basically see what type of insurance or whatever, how I would go, and then probably proceed over to the claim management. And probably from there, well, hold on, I have to start the claim first. And
Yes.
I will go to claim management, because we're talking about I'm gonna do it. And then I probably would go into the claim submit.
Okay. And know that this is a circle, so you can jump, skip, but just know that it's a continuous loop. That's a good one. Good job, you guys. So when we're looking at the revenue management, just like they mentioned, it's a network of people getting paid. Okay. Think of it as a micro market. And everybody just wants to make sure that they're not getting overcharged, they're not getting underpaid, which can be kind of tricky, right? Because we as consumers do not want to be overcharged for services. However, the facility is trying to make sure they're not getting underpaid for the facility. So I think of it as a song and dance, right? And that's why you see the word cycle. It's a cycle of making sure that the left and right come together in the middle, and hopefully the outcome is not crazy or bad. So those were really good examples.
So are you saying basically when you're doing coding, so coding, it basically starts everything off, like, and then it's kind of like,
Yes.
like a football team or whatever, you guys are working together. So if one slack up, it just falls, like that's.
Yes. The understanding the CPT code is important. So those of you that want to go into coding, making sure that you're on your game is going to be essential, because let me go back to the codes. So you could have something that's 599.1 that's going to be different than 599.0. Granted, I made these up. So I don't even know if you could find them, because I'm not a coder. So but I know when you had your example, I saw 598 and 599. So, this is the diagnosis, 599.0, but you could have a 591.1. So I know for me, sometimes when I'm typing fast, that 9 and that 0 being close, that could be the difference between, a total knee arthroplasty where they're taking the bones out of the knee and putting in new ones versus a toenail. You know what I mean? Like a hangnail, which is definitely not as expensive. So just keep that in mind when you are going into coding, making sure that the diagnosis is right. But there's so many codes. So you have the diagnosis code, you have the surgical procedure code, the prognosis code. So, there's a lot that go to coding with that one patient. All right.
I wanted to add, because I already work in medical records, like
Oh,
we
nice.
always do like monthly checks for all the Medicares, so they all have to like make sure all the codes match for the claims. And then they also do now have this new system called PDPM, where they have to check every single Medicare patient and anything they're missing, so that the chart is complete. So it's a whole new other
That's good though, because you have to have those fail safes in place. And I don't want you to put your place on blast, but do they have something in place if a code is wrong? It's great to have it, but to err is human. So do they have anything in place that they can kind of help the patient if one of the codes was off? And I'm just curious.
I'm not really entirely sure, because it's our MDS does most of the coding.
Okay.
And then we
Okay.
just, like for ours, we input when somebody gets admitted, we input whatever is the obvious diagnosis, and then they will do corrections if needed.
Okay. Okay. And then I had someone else say, yes, I think at their facility, they do have something in place. In the military, it's a little different because we don't use CPT codes. We use humans. And we just have to make sure that we are putting in the correct information so that the correct care is being documented, so that when the individual gets out and they have their thick medical record with them, they can take it to their civilian provider. And a lot of times they can kind of convert that military document over to the civilian sector. Me, I stay in the VA system, so all of my military stuff that I've had stays there, in TRICARE and in the VA. So I kind of like do it that way, but it comes with a cost, just so you guys know. All right. So when we're talking about patient access department, this is another chapter or another section that was brought up. So I want to kind of hit on it so that when you guys take that quiz, you're prepared. Many health care facilities like hospitals, patient access areas, manages registration, insurance verification, billing admissions. They are responsible for also capturing different demographic information on each patient. Now, of course, there's places where you don't have to put your demographic. It'll say don't want to or whatever, but they try to show that they are providing access to the general public. Okay, so you have your COB, which is your coordination of benefits, where it determines which insurance coverage is primary, secondary, or tertiary to territory. All right. And they are the ones that'll kind of start that off. So you put in your claim, or you want to, let's say you want to go get a mole taken off. And based on the insurance coverage that you have, that it is covered. And you start the process a lot of times before you even get to see a surgeon or a dermatologist or whatever for that particular procedure. But it's going to start at the patient access department, where they are getting access to you to get that information started rocking so that they can better provide care for you. Do you guys know the steps to a medical claim process? And if you work in medical records, you can't answer. But does anyone else have an idea of the steps to even start the claim? So you're at patient access and you're ready to go. What do you think you have to do first? And I want to use the example of, this is the first time you're using Facebook. What did you have to do first?
You have to provide sorry, I'm losing my voice. You have to provide your basic information, name, birthday, just the most basic stuff, the kind of stuff that they call you when you're making up an appointment and they have to have your birthday and your full name. That's step number one.
Yes, registration. That is correct. What's next? Will they just see you if they think, you know what, I like her hair today, come on in? Or those shoes are nice. Yes, sir, come. Or I like his haircut. Yeah, he look like he can come on in. Is that the next step? What's the next step? What do you think?
Well, they always ask me if I have insurance, like after.
Bam, that's it. Number 2. I was about to say, think about what Will Smith said. That wasn't Will Smith, guys. That was me. Okay, it was me being Will Smith. I know, Hillary. I know, girl. I know. So yes, registration, financial. They want to know, can you pay? Do you have money? Can you come and pay for this? The other things may be a little bit not as out in the front, right? So you have your patient check-in and check-out. So you've registered, they've said, yes, you have the money, you can come. So then you're checking in, you're checking out, and then that's your process. So then the coders come in. They check for coding and billing compliance, making sure that if you're here for the snuffles, you're being charged for a cold and not anything else. Your claim is transmitted, monitored by the prayer adjunct. Then they generate a bill. They generate a bill for you and your payee. So I don't want to just say insurance, but your payee, so that they can assign the patient payments and arrangements. Okay, that's the steps. That's how it starts. You register, come on in, you got that money. Let me check in, check out for my appointment, because you have to have the appointment. That way the coding can begin. Monitoring of the payer to make sure where they at, make sure they're not going nowhere. They generate your bill and then assign how much is going to go to the patient and how much your insurance is already paid for you. Types. So the rest of the chapter just really breaks down the different types. So when you're talking about commercial, you have government, commercial, managed healthcare, your health maintenance organization or your HMOs, preferred provider organizations, point of service plans, where I think of point of service plans more as like, I look at dental, where you can pick and choose. Do I want to have an orthodontist? And this is on a smaller level, but do I want an orthodontist? Do I want, my teeth are like Cardi's was before she fixed them, so I need everything done? Or am I just going to get somebody that has some cleaning? All right. And then you have government sponsored healthcare plans. Can you guys name some? And I've given you one already. Name some of those government sponsored healthcare plans.
Does that include military sponsored?
It does.
There's one called Champ something.
Yes. Champ VA. That is correct. Good. Anyone else? There's a lot that you guys can come up with. Think about children. Is there something for children?
Oh, Medicaid?
Medicaid, that's another one. So with Medicaid, what do you normally hear with Medicaid? Medicaid and
Is it low
Medicare.
income, Medicare?
Yes, Medicare, Medicaid. You have the VA. I mentioned the VA, Veterans Administration. For those who are still active duty, you have TRICARE and their families. So you TRICARE, TRICARE Plus. There is one called Indian Health Services. I don't know if many of you guys know about that. If you get hurt on the job, what's that one?
Disability, or yeah.
Disability Workers' Compensation. Good. Children's Health, and then Health Insurance Marketplace. So those are some of the ones that are government sponsored healthcare plans. All right. Case management. So now you have your case, you have the role of a case manager. One of the major types of community aftercare is where you have to take care of the sick after they've had a procedure. Okay. We're going to move into after payments once a patient has left the facility, the ASU, ambulatory surgery center, and they're still requiring some type of management. So I put up two ways in which they are looked at, where we focus on the health of the population, of the individual, and we're bringing it all the way down to the ability of different health outcomes. The other way they look at it is when you assess the patient, you're looking at it the both way. You're assessing the patient. We have to come up with a plan for that patient. We don't want to add more injury to the patient than they need. We got to find a facility. Are they going home? Are they going to a rehab center? How are we going to coordinate that? We got to evaluate the situation of the individual, and there's always a patient option for advocacy. I say option because there are those individuals that's like, I don't need no help, I'm good. And you're looking at them like you're going to fall as soon as you leave this place. But you can't say that. You got to be professional. You have to be like, okay, get the ambulance ready, because as soon as they leave, they coming back, right? And those are just those individuals. An example of a case management, I want you guys to think of assistant with health needs, daily living activities, assistant with transportation. It may be just they need to get transport to their home because they do have someone waiting. However, that individual can't get to them at the time of their discharge. Something simple like that. I bring that up because here's a scenario. You guys ready? You guys ready? We have patient John Doe, post-op total knee arthroplasty, and he requires rehab. Patient lives alone. His family is located in another state. He is in Hawaii. His family is in Washington, D.C. Patient has a BMI of 45%. He is also diabetic. He's recently employed and his insurance will run out in 60 days. What are some of the things that Mr. Doe will need help from his case manager with? So I'll go over it again. Patient's name is John Doe. Post-operative total knee arthroplasty, and he will require rehab. Patient does live alone. His family is located in another state. He is in Hawaii. His family is in Washington, D.C. His BMI is 45%. He is diabetic. He's recently unemployed, and his insurance will run out in 60 days. How can we help him?
I think he needs somebody to help him figure out insurance issues, because I don't think rehab, I'm not sure, I have not been through that kind of rehab before, but I would think there needs to be some kind of extension beyond 2 months if you're having a total knee replacement. So I would say likely he would need a case manager to help him figure out what his next steps are to extend his insurance or get set up with a new one. I'm guessing through the ACA website, but be something a case manager would help with.
Yes, that's good. That is one. So that's good. So we have a case manager. We're like, number one thing that we have on this list is we've got to fix his insurance. What other things do we need to look at with Mr. John Doe?
How will he afford to get rehab or some kind of managed help with post-op? Or is
Yes. Number two, so we've got his insurance. Now we're looking at how we're going to get him taken care of post-operatively. There's a couple other things that he still needs help with if he's willing to accept it. What do you think they are?
I think one, sorry, I think one would be to try to figure out how to get his BMI down and make
Yes.
sure that he has like diabetic medication. So he's taken care of in that aspect. I mean, I think that would be the first thing I would do as a case manager.
Okay. Okay.
I'm sorry.
This
I'm
is
eating.
good. No, that's okay. You need to eat. Nutrients are important.
You know,
Let's see. I see the chat.
Brian,
Mhm.
choked on one of them because I was trying to come in too, but that's okay.
Miss Justina, go ahead, ma'am. Go ahead. Because it's true. BMI
Yeah.
can really be hard on your knees.
Yeah, so like, see, what type of therapy he can get, because I mean, he's already going to have like a knee replacement, so he's going to have to go through some therapy. So I would probably see what type of therapy can he get with him having a high BMI and being in diabetic. It would be a special type of assistance that he would need with that.
Yes. And then there's one more thing that I'm surprised no one has hit on yet. So he lives alone. His family lives in Washington, D.C. He is in Hawaii. Home health. Yes. We've got to find some way for him to get to this area. That's right, Miss Hillary. Transportation. And one of the questions is, can you get one of your family members here, sir? Because we really want to make sure you're not left alone, right? We want to make sure that we are providing the best for you. So with everything that you guys have put together for John Doe, do you think he has a chance? Y'all supposed to say yes.
Yes.
Yes. We so some of the things we're working on for John Doe, let's recap. We are I see somebody's the chat. As long as he's on some good antibiotics too. Yes. So we want to make sure that he does not get an infection. A lot of diabetic patients, especially with a BMI that high, are prone to different infections. I worry about ulcers because I'm not I'm not sure that he is very mobile at 45% BMI, and he's 5'3". I'll throw that in there now too. So he's 5'3" with a BMI of 45%. Okay. We have, yes, Miss Rika, they need to incorporate his planned care. I would really try to see if we could get some of his family member here too, so that he is not left by his own, not saying that he won't take care of himself. However, unfortunately, with a BMI of 45%, and we don't want to treat the patient as a number, but yes, and discharge planning. We still need to be realistic. What things that weren't brought up, his age. Is he a 50-year-old, 70-year-old, 90-year-old? That's going to play a big play in it on whether he is mobile, and does his family have access to him? Is there anyone coming? Being recently unemployed, I'm worried about his mental health as well, right? I want to make sure that Mr. Doe doesn't spiral because of everything that's going on. Recently unemployed, would be considered morbidly obese, he has diabetes, and he's alone. So mental health is another thing. Right, nobody, he's by himself, no partner, no wife, no husband, he's just living his life in Hawaii, drinking coconut water by himself. So poor Mr. Joe. Let's see. Is he healthy enough to get the surgery? He is borderline healthy. He is in Hawaii, and his surgeon feels that he has lost. So he was 50% BMI and he got down to 45%. So the surgeon is, and mind you, we're just making all this up, but these are great questions. So the surgeon feels that he is able to get the surgery in 1 month. So this is all being done prior to him even having the surgery. And then he had the surgery. So he had to get down to 45% before he could even have the surgery. And that's a really good question. A lot of times when we do bariatric cases, this patient has to get down to 400 pounds before we can even consider them for that particular surgery. And granted, 400 pounds, you're probably thinking, oh my goodness. Yes, we have a bariatric bed and most operating rooms that do bariatric surgery, and they're required to lose weight to get to 400 pounds before we will even look at them. So that was a really good question. Okay. Here's the wrap up. We went over the quote of the day. Sometimes there are going to be tough days. Just remember to brush yourself off, come back stronger, and the new day will be better. We looked at the fact that you guys have a scenario with some census data as opposed to saying the S word. And we kind of broke down one of the scenario question types that you will see. I wanted to remind you that if there's one of the scenarios that you're having a tough time with, just reach out to me and we can go over it, because census data, I keep trying not to say the S word, can be overwhelming at time, but it's only one scenario with 9 questions, and the data is going to be used for all 9 questions, okay? We went over chapter 14 and chapter 15, really concentrating on reimbursements, claims, what is really health insurance in the first place. Today, our last scenario that we brought up kind of brought things home to another level. We talked about a patient who was presented with a lot of different issues, and we put ourselves as case managers to see what was the best way we could help him really help himself to get better. You guys all did really good, especially with the scenarios, because this is something that you may see, you may hear, as you're coding different things, you may have to code for ambulance or aftercare from a surgery. That's really it. It's 5:54. I always enjoy meeting with you guys on Thursdays. And can you believe next week is week 8? Like craziness. So week 8. All right. Check to see who the next person's gonna be. It's really me, guys. I just keep saying that because I don't want y'all to be like, oh, my teacher got all these celebrities. It's just me. It's just me. I'm not trying to get in trouble, but you know what I'm saying? I'm just trying to have a little bit of fun. If there is nothing else, let's see, I see another question. Okay. If there is nothing else, I will bid you guys adieu and live long and prosper.